Well, good afternoon, everybody, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name's Jason Belden, and I'm the Director of Emergency Preparedness for CAF. We have a few guest speakers today. I ran out of space, but there are more guest speakers than I have listed here, but Ken Rasmussen, Joel Ayala, Travis Godden, and Patty Owens will be joining us today as well. It's March 12th, 2021. It's 1 o'clock in the afternoon. And as always, many of the resources that we collect, along with the guidance documents that CDPH puts out, CDC and folks like that, those are all listed on the caf.org website, /resources /coronavirus. You'll get all the information that we've collected there. All right, we've got a busy agenda today. We're going to talk about AFLs. We'll talk about a vaccine update, and then our guest speakers we're going to have a discussion on disinfectants. I know there's been a lot of questions, and we'll on what types of chemicals to use and things like that. They're far outside my scope of expertise. So I gathered some subject matter experts to help us kind of explain some of that stuff, and we'll get to that as we progress through the program. Today's our normal introduction. The speaker's opinions expressed on this webinar may not reflect CAF's official position. The speaker's opinions expressed are their own. These webinars are brought to you through grant-funded programs with the California Department of Public Health and the Los Angeles County Department of Health Services. I have no financial conflicts, and the speakers today represent TKO Medical, and they'll introduce themselves and the company that they represent when they present. The intent of the webinars is to give you a situational report of the week's activities, some forecasting for where we anticipate the next week's response to go, and highlighting best practices where we can. All right, so let's hop to the first one, since I know this is foremost in folks' minds, is the AFL 20-22.6, guidance for limiting the transmission of COVID-19 in long-term care facilities. This is really our visitation AFL. And before we even get into this, if you're in an intermediate care facility, both Patty has confirmed with CDPH that this AFL does not apply to intermediate care facilities. For intermediate care facilities, the requirement is to follow the QSO. And if you're an intermediate care facility and you participate in the forum, you'll have the information. But if you're an ICF and you have questions about your limitations for visitation, please reach out to Patty or myself, and we'll walk you through the QSO. So for this, I'm going to stick to just the skilled nursing facilities, and then as we get to the Los Angeles County differences, we'll touch on those. Now I'm going to try to explain these in the manner in which where there are limitations, and then we'll talk about what is currently allowed and you know, pretty much what's always been allowed, and then we'll talk about some of the still outstanding issues that we have to get resolved with CDPH. So obviously the AFL is for expanded opportunities for indoor and in-room visitation, including those with physical touch. It talks about infection control measures for fully vaccinated residents and visitors. And the AFL goes on to say that any visitor entering the facility, regardless of anything else we talk about, their vaccination status, the color tier, all of that stuff, every single person entering the building needs to be screened for signs and symptoms of COVID-19, wear appropriate facial covering, and perform hand hygiene while they're in the facility. We know that we're going to be required to provide visitor quote unquote PPE for yellow and red zone where and when it is allowed. And we're going to cover, you know, those limitations where CDPH has said you have to offer it. And then anyone with COVID-19 symptoms or that has been in close contact with a confirmed positive case must reschedule their visit. So those are the standing issues that apply to everybody across the board. In terms of the indoor in-room visitation for residents and facilities that meet specific criteria, I'm going to talk about what the restrictions are for purple counties, and then we'll talk about what the allowances are for other counties. So if you're currently in a purple county, these are the restrictions that would apply while you're in that purple tier. And we realize a lot of counties are going to be moving out of this tier soon. That's our hope, and that's every indication we're heading that direction. So this may be a limited time in which you have to operationalize these, but I want to go over this because it is applicable right now. So for indoor in-room visitation only, this does not apply to the compassionate care situations or outdoor visits or any of those other things, ombudsman, surveyor, any of those other types of visits. This does not apply. But for indoor in-room visitation in a purple county, the visitor needs to have tested negative within the previous 2 days via a PCR test, and you can use your POC antigen test in lieu of that PCR test. I know that CDPH had made some statements about not having to report the results of those tests unless they were positive. I just want to say that licensing does not have a specific requirement, but the laboratory department does. And if you're a CLIA waived lab, meaning you have a CLIA waiver to utilize those point of care devices, you are by law required to report all positive and negative test results. And there is an actual CDPH guidance document that was released in September of last year, and that's linked on the bottom there. And that gives that exact information that we must report. So if you're already utilizing the POCs and you've got that reporting piece down, whether it's you've got an agreement with your health department, if you're in Los Angeles, it could be, you know, that they've chosen to have you just report positives. That whatever you're using now for that reporting mechanism, we don't anticipate that changed with this AFL. So you'll have to continue to do all that stuff, and that's our understanding. I've approached this, and we've approached this with folks at CDPH, and I think they'll give some clarification on their next webinar on Wednesday. So stay tuned for that, but definitely our understanding is that regardless of what Heidi said for licensing, for the other side, you are required to report to CalReady those negative and positive tests. Los Angeles and San Diego have different reporting mechanisms for those, but my assumption is they also still require that. So definitely check to make sure with your health department to make sure that you don't have to report these negative antigen test results. And then for indoor in-room visitation in purple counties only, now this is purple counties only, fully vaccinated visitors, that means the visitor is fully vaccinated and the resident is fully vaccinated. They may have brief, quote unquote, brief limited physical contact with the resident. And the AFL goes on to define what brief is, and it says brief hug, holding hands, and then it went on to say feeding, which is not a brief, it's not a brief activity. It's not a short-term thing. And a question was posed to them on the webinar, and we posed that, well, feeding is not really a brief activity, and that would be considered more on the compassionate care side. So I think, you know, for feeding, you know, in these purple tier counties, I would say, you know, brief hug, yes. Hand holding, possibly, if you can, you know, limit the amount of time in the same space. That's great. You know, we heard that gentleman talk last week about the time in which you're spent in the zone in which it's, you know, potentially impactful. You know, we want to limit that time that we're in that space. And so I just, you know, I know it's allowed, and I think, you know, folks, if you can operationalize that, great, but I don't see that as being included in brief, and I think CDPH would view it the same way. So They did not answer the question, and frankly, I'm not sure I have a great answer. I think some of this is going to be left up to surveyor discretion when they look at whether these are brief encounters or not. In terms of all of the other county colors, including the purple tier, these other restrictions or criteria apply. All the visitors and residents should wear appropriate facial coverings during their visit, and they need to maintain that 6-foot physical distancing. Fully vaccinated visitors of fully vaccinated residents may have brief limited physical contact with the resident. There's that quote unquote brief term again. Try and make an indoor space specifically for family to do visitation. And I know that the easy part would be to have it in a resident room, but there causes issues with line of sight and being able to kind of monitor those visits if they're in a room. So our suggestion would be, or recommendation would be to dedicate a space for that rather than doing folks in their room. But you're going to have bed-bound residents, and those folks can't go anywhere. And in that case, you obviously do the visit in the room, but the roommate should not be present if at all possible. Now, if both roommates are bed-bound, you're going to have to do your best to maintain those separations and create some kind of barrier for privacy's sake. And then it goes on to state that full PPE must be worn for yellow zone visitation. And we don't see anything here for red zone visitation, and that's intentional. They've left the red zone visitation alone to, kind of get through that red zone thing. And all of the other compassionate care and outdoor visitation and all that stuff can stay for those folks in the red zone. But for the indoor in-room visitation, there's no red zone included in this AFL. And that's important to note. But for the yellow zone, full PPE must be worn for yellow zone visitation. And we did talk to CDPH about, what kind of risk or exposure risk that leads to us, or do we have to fit test these folks? Because an N95 is a respirator when it's been fitted. It's not PPE if you just hand it to somebody, then it's just a mask and or a facial covering. And their recommendation was to walk the visitor through how to do a seal check. My suggestion would be if you're going to do that, I would obviously talk to these folks before they arrive. If they have the ability to have access to a computer, have them watch the CDC's video on obtaining a seal for an N95 mask so that they're prepared on what they need to look for when they come in. I frankly am not super comfortable that handing somebody a mask relieves you of any liability. But this is like putting lipstick on a pig. We just got to kind of deal with it as it comes, and we'll try to work on the CDPH to get them to recognize that it's just not fair to put all the risk on
Yeah, Jason, this is Patty. Yeah, it's definitely something the facility you want to look at from a risk management standpoint with the, within their own internal organizational structure to see what processes to put in place and what policies you're going to want to update and how that's going to, what type of risk your facilities identified and that sort of thing. So I just wanted to add that in.
Yeah, perfect. Thanks, Patty. And so for the outdoor visitation, they went on to state in the AFL that outdoor visitation is still the safest when weather and space permit. If you do outdoor visitation, and that outdoor visitation is still, an option for those, when weather permits, and we've got good weather today. Yesterday was terrible. I don't know what next week is, but you've got to kind of continue to do that outdoor visitation. I would, especially in purple counties, this is the counties where there's still community spread. you know, if you can, I do think that is the safest space. We need to continue to follow all the other safety procedures and requirements for indoor visitation. Visitors got to follow those core principles that we've talked about a number of times, and the staff should evaluate the need for monitoring these visits and address issues as they arise. And the AFL was pretty clear to state that if you see issues where folks have difficulty maintaining those core principles, it is within your right to ask that person to leave. So, and that's an uncomfortable conversation to have with somebody, but we want to encourage folks to continue to do the infection prevention and control measures as they're recommended. It's not, I know we're a year in, I know we need to keep going just for a little bit longer. And that's what we've got to stress to our families. They did go on to say that facilities can limit the number of visits per resident at one time and limit the total number of visitors in the facility. And that should be based on the size, your operational considerations. Can you actually monitor compliance? Do you have the physical space set up? How big is that physical space? A lot of, you know, individual site specific information you'll need to be able to kind of figure out, but you are allowed to kind of schedule these, and it's actually a suggestion to help you operationalize these and make sure that they're being done in a consistent manner is probably best to do it on a scheduled basis. Facilities that are scheduling these visits for a specific length of time should ensure as many residents can visit as possible, and a visit should be scheduled for no less than 30 minutes. And then obviously the only time we would want to limit that is, you know, if somebody breached one of those core principles and we had to ask them to leave. All right, so I'll hop on to the next section here. So let's talk about what they've essentially allowed for vaccinated residents in green and yellow cohorts, and how that differs from unvaccinated residents. So only visitors of vaccinated residents can have indoor in-room visits in purple counties. Visitors of unvaccinated or partially vaccinated residents may have indoor or in-room in the other county color tiers. So any of the other color tiers, visitors of unvaccinated or partially vaccinated residents can have indoor in-room visitation. No physical contact, and all of the other rules apply. Now, when, you know, many things within this AFL required you to ask the visitor to prove compliance or to ask for information that would prove that they're one, you know, COVID negative, two, what's their vaccine status, and three, screening for those symptoms that are consistent with COVID. Now, how you document this is really up to you, but, you know, we know that if you're putting actual medical information into these forms that you're saving, those become HIPAA compliant documents, and now they need, there's other stuff that goes with the kind of storage of that documentation. What we've seen some other providers do in terms of documenting compliance is they've designed a waiver that has covered, you know, kind of talked about, we will provide you PPE, and you're attesting that you have received a COVID positive or a COVID negative test within the last 48 hours, and or, you know, you've tested or you've had 2 doses of the vaccine. And then along with the general acknowledgement of the risks and limitations inside the building when they visit. Obviously the risks, exposure to COVID are real, and the limitations, they would be limited to where they're allowed to go within the facility. You know, I think this is a little bit site specific. It wouldn't, you know, you'd have to kind of look at what you're going to provide and what you're going to ask the visitor to attest to. But I think this may be a better way or another way for you to document compliance. and it may offer you some protection on the back end from liability risks. Patty, did you want to add anything else on kind of having folks on
Yeah, and yeah, I mean, the best practice probably would be having it part of your, like Jason said, having it part of your screening process for the visitors, you know, and to prove your compliance for a survey visit or anything like that, or liability, you just might want to have some type of screening process, update your policy to say what your screening process is, make sure all your staff can speak to what it is really well, so that everyone's answering the same way what the process is, so that CDPH, you know, feels like staff are aware, they're educated on it. Then also, you know, your part of your screening process could be, like Jason stated, some providers do it in different ways. Again, you're going to go back to your risk management team, you're going to discuss this, find out how you want to do it, but updating a visitation screening form, maybe when they come in with some set questions where they mark yes or no, and then they sign it off, and you keep that in a file somewhere, which it wouldn't contain any really detailed HIPAA compliance, just going to say that they, you know, maybe they said that they've tested within the 2-day period and they're cleared to come in, and, you know, just something that's going to cover you for compliance, and then looking at your risk management, however your company wants to deal with that portion.
Yeah, perfect. Thanks, Patty. Yeah. And hop to the next slide here. So I'm going to go over this Los Angeles County specific information. And I know this doesn't apply to the entire state, but it does apply to roughly a third of them. So I want to just draw these distinctions for Los Angeles County that's a little bit different than the remainder of the state. And also there's a link in the bottom of this section here. At 2 o'clock today, Los Angeles County is giving a webinar for all the skilled nursing facilities to cover the differences and the allowances. I'll just give you a brief kind of bullet points of where Los Angeles County differs. Los Angeles County says all unvaccinated or partially vaccinated visitors should document a negative COVID test prior to visitation, regardless of the county tier and vaccination status of the resident. So only if the person has been vaccinated do they not need to test. For facilities where less than 75% of the residents are fully vaccinated against COVID-19, facilities must continue to restrict communal dining, group activities, non-essential personnel, and contractor services when LA County is in the purple tier. Now, once they get out of that purple tier, I'm not sure where they're going to go, but at least for now, LA County is still in the purple tier, I believe. The following apply regardless of what color LA County is in. Fully vaccinated visitors, so meaning right now, fully vaccinated visitors can visit fully vaccinated residents indoor in-room. Fully vaccinated residents can participate in communal dining and group activities. Unvaccinated or partially vaccinated residents can participate in communal activities outdoors with appropriate prevention and control measures. That goes back to those same core principles that we talked about, 6-foot distancing, masking, things like the hand hygiene, all that good stuff. And the link at the bottom is to register for the 2 o'clock webinar with Los Angeles County. And if you're in LA County, I highly recommend you tune into that one as well. Going on to the next AFL, and as you have questions, I will get to the questions at the end. I see a bunch of questions in a question box. Go ahead and enter your questions, and we'll get to those at the end here. I'm going to quickly go over AFL 2066.1. This is an update on the guidance for provision of home dialysis services and SNFs. This is not necessarily COVID specific, but it does clarify that the reason why this came up is I know a lot of folks have moved to doing dialysis at the bedside. There's some conversations at OSHPD that folks are attempting to to really kind of codify or make this a permanent fixture in buildings, and OSHPD had addressed it with CDPH, and CDPH adjusted their AFL to talk about specific things. One, SNFs can only administer dialysis at the resident bedside. It's done through an agreement with an ESRD or CDC. Facilities must contact OSHPD for certification of the building standards prior to the use or the beginning the contract. Permission granted in the other AFLs on the waivers allowing SNFs to submit an application and begin providing care prior to approval and licensure does not apply to adding dialysis services. So that's something that we wanted to make you aware of. If you're going to do this, you must go through the central applications branch for exchange of service. The AFL is linked there as well. There's a link within that AFL that takes you to the change of service application and walks you through that process. So it's I don't know from what OSHPD's purview they're going to require. This was news to me, and I reached out to the building standards unit at OSHPD. And once we get a list of what the requirements or what they're looking for when they go out to say, yes, you can do this. Once we get a list of all those things, we'll put it on the forum, or maybe we can address it here in this webinar.
And I also wanted to add in, Jason, again, this is Patty, that this is for the initial licensing of getting your license changed. So it's for the initial. So I just wanted to make sure I clarified that.
Perfect, thank you. And now we talked about this briefly, AFL 2108.1 last week, and he came out last Friday. Yesterday, the CDC, or on Wednesday, the CDC changed their quarantine guidance for healthcare personnel. And I did not have a time to add all of the CDC stuff in here this week, but I do know Dr. Epson addressed it briefly on the call yesterday. And she said to us and to the folks on the conference call yesterday that the CDPH will release updated guidance that incorporates this new information from the CDC. But the highlight here is following a high-risk exposure work restriction of asymptomatic healthcare personnel who have recovered from COVID in the past 3 months or have been fully vaccinated is not necessary. And that's the big highlight here. I don't want you guys to act on this yet until it hits an AFL and it gets to you guys, but I anticipate that will come out very soon. And if you want to gather information or read the entire update, it's linked there on the bottom. All right, with that, we will get to your questions towards the end here. I'm going to just talk for a second about vaccine planning, and then we'll hop over to our guest speakers for today. What we know is that they're really looking at two different pathways at the state. Nothing different than what we learned last week. Both involve the long-term care pharmacies being the one delivering ongoing vaccine doses to the providers. One of the things that we asked the state was, now that the J&J vaccine has been approved, could there be a way of utilizing that one dose vaccine for discharging residents from hospitals into the SNF setting? And they all thought that was a great idea. It's a beginning part of that process, and we don't know how the third-party administrator or the TPA program is going to allocate these doses and where they're going to go, but that certainly seems like it would be the least impactful for you guys and the easiest to operationalize if the acute hospitals had access to a one-dose vaccine that they could give to folks before they discharge, and that would be great. So we're going to continue to explore that opportunity. And one of the things that came up from our conversations over the last couple of days about the vaccine is your long-term care pharmacy signed up through the MyCalVax process? And if your long-term care pharmacy is not signed up, please tell them to contact us ASAP so that we know who they are and can get them through the sign-up process. It's really important. So if you guys have a long-term care pharmacy. If you've not already asked your pharmacy if they signed up, ask them if they've signed up. If they haven't, gather their information, see if they're interested in participating in the program, and then connect them with myself or with Deanne, and we'll try to get them through the process as quickly as possible. The decision from the state is going to come very soon. So if these long-term care pharmacies are not in and approved at the time the decision is made, they could be left out. And that could leave you in the lurch with not having access to that. So we've got to find from our pharmacy partners if they can handle that. All right. I want to hop to our guest speakers for today, and I want to introduce Ken Rasmussen. And Ken's going to give a brief overview of TKO Medical, and then he'll introduce the guest speaker to talk about disinfectants. And Ken, why don't you go ahead and take it away?
Great. Can everybody hear me there okay?
Yeah, we hear you great.
Okay, great. Anyway, mine's Ken Rasmussen, and Travis Godden is my business partner. We're the founders, CEO, and president of TKO Medical. First of all, we want to say thanks to Jason, the CAF leadership team, for inviting us to be a part of this meeting. We are a CAF preferred provider and are grateful and excited for the opportunity to be a part of it. We have been a complex rehab company for many years and still are, and helped hundreds in California. But due to the pandemic, like many vendors, we needed to find some options to serve the skilled nursing space. So then we came across CLO2 and their products, which are amazing. And we knew after becoming the exclusive distributor for them in skilled nursing that we could help you, your staff and residents, to stay healthy and prevent future viruses in your buildings. If after hearing the presentation you're interested, we'd be happy to come out and do a free testing of the condition of the bacteria in your buildings. But in order to have an understanding of how we can assist you better, we have with us today Joel Ayala. Joel is the master trainer for CLO2. He's going to go through the products and then answer any questions you may have. Joel? Are you there, Joel?
Joel, you might be on mute.
Let me check with him.
Joel, it does look like you are self-muted. If you want to just click the microphone on your control panel, we should be able to hear you.
Click that red microphone.
Maybe you can talk through your phone, Ken.
Oh, there we go.
Yeah, so there's there's like a red microphone up at the top. You should be able to click that and get in it. The microphone should turn green after you click it.
You know what I'm gonna do? I'm gonna try and patch him in through my phone here. Go ahead and try and talk to Joel.
Hey, Ken, that's not gonna work.
Yeah, I think there's gonna be too much of an echo.
Well, tell you what, we've got a lot of questions. I'm gonna hop to questions. Why don't we see if we can get Joel's mic squared away, and I can hop to some of the questions.
Yeah,
I don't want to.
He's gonna log off and log back on again. Sorry about that.
Oh no, it's okay. It's okay. All right. So as we kind of pivot away for just 1 second while we wait for Joel to join us, I'm going to try to dive into some of these questions. We'll get to as many as we can. So the first question here is, what is the recommended observation period for a fully vaccinated resident who is being readmitted back to the facility after being in the hospital for 6 days? And Angie, based on the new guidance from the CDC, the change in quarantine times is only for healthcare workers. In this instance, I believe that that person would still have to go into the yellow zone. I would say that we could count those 6 days towards the aggregate total of time for waiting for symptom development, provided the hospital was not in an outbreak status, and the hospital was monitoring them for symptom development. The next question is, can we use the Abbott Binax antigen test instead of the POC device? And yeah, absolutely. So the Abbott Binax Now cards are one of the 4 approved point of care antigen testing modalities. It's much easier to operationalize. And if you have that and you've operationalized the reporting and you're all good there, you absolutely can use those. And I'll check back. Are we able to get Ron or Joel? I mean, if not, I'm going to keep rolling on questions, and you guys just interrupt me.
Yeah, he's trying to get in still right now, rebooting up.
Okay,
So
no
I'm on the phone with him right now. I'll jump in as soon as I know he's in, or as soon as he's in, he'll jump in.
Yeah, for sure. I got a ton of questions, so I can keep going as long as it's necessary. So.
Sure.
All right, so the next question we have is, hi, the AFL does not provide specifics on types of visitors other than vaccination and testing. What is your take on allowing children, especially very young ones? Well, children are definitely much more difficult to get them to monitor the core principles and follow those for sure. I think if you have a conversation with the visitor, about the requirements of maintaining social distancing, maintaining the space in which we've organized for you to safely be able to visit, and you need to stay within that space and stay contained within your area. I think it certainly can be done. I'm a parent, and I don't think it would be that difficult for me to get my child to sit still, but it does require somebody from the family to do it. In terms of folks that let their kids just kind of do whatever, you really have to let them know. Look, it's very important that we follow these core principles to the letter, and if you can't follow those, we're going to ask you to cut your visit short and reschedule, or we're going to try to develop a space in which it's less impactful, to have a young one run around. I see much less of an issue with it if you're doing outdoor visitation than inside visitation. All right, so I'm going to get to the next question here. All right. All right. Is large communal indoor space treated as outdoor or indoor visitation? And that's a great question. So in the AFL, it defines outdoor and indoor communal spaces as one kind of area, and the indoor in-room visitation as another area. So anywhere you see the outdoor or large communal space, those kind of had the same requirements. And then the indoor in-room visitation is the one that has the restrictions. Do we need to offer, next question, sorry. Do we need to offer N95s for visitors in the yellow zone? Based on CDPH response, it appeared mask surgical, but not sure about cloth for source control would be appropriate. Now, the AFL says full PPE. Like I said, they can say full PPE, but an N95 is not a respirator unless you have been fitted to the respirator. So it's not full PPE if it's not been fitted. So you can't do that. I think it's realistic to either offer them an N95, and if you want to, counsel them on how to fit it or how to get an appropriate seal. Like I said, I have some concerns about what kind of risk that puts you at, but if we can get that in writing from CDPH, then I would be more comfortable with providing them a surgical mask, or talking to them about double masking and things like that. Until I see it in writing, I can't tell you to act on it. And they haven't put it in the notes yet. So once they put it in the notes, then I could say, oh, the boss said this is okay.
Yeah,
and then we can
come on now.
Oh, do we have Joel?
Okay, guys, can you hear me?
Oh, yay, fantastic, Joel. Okay, folks, I will get back to the questions at the end here, and I'm going to turn it back over to Joel so he can give us his presentation. How you
Hi there,
doing, Joel?
guys. I am doing great. Sorry for the little techno problems there, but we got it. We just put a little CLO2, kill that virus. We're back on.
All
So,
right.
okay.
You let me know to advance the slides whenever you want.
Okay, sounds good. So for some reason, I can't control my slides, but you can hear me. That's all that matters.
Yeah.
So my name is Joel Ayala. I was introduced as a master trainer for CLO2 products on a national global basis. What I do is I train people how to properly disinfect, deodorize, and protect your buildings from every pathogen known to man. So what does that mean? That means that we pretty much protect you from everything out there, because right now we have COVID viruses that are out there. We have coronavirus, we have the common cold, the flus, and a few other things out there. So our products actually work with a 6-law kill to kill every single thing known to man. So our Selectricide, which is a CLO2 product, our Selectricide is a disinfectant. It's EPA and FDA approved product. So what does that mean? It means you can use it. It has many advantages. You can use it for washing fruits, meats. It's a disinfectant on a very broad range. It has no enemy. It's a very inexpensive. It requires no rinse on any surface. It leaves nothing behind. So once it's put on there and it dries, it leaves no residual anything behind. So you don't have to rinse like a lot of the products that are out there used today. Ours, you don't have to rinse because it will dissipate with approximately 20-25 minute time. Once it dries, it's gone. So if you put it on fruits and vegetables, it's 100% safe, and that's why it's an FDA approved product. So if you would go to the next page, I actually thank you for controlling that. It can be used for in every range. So you can use it to wipe down your counters, your bathrooms, all the door handles, all your high touch areas. You can also use it for floors. You can use it in every surface that you want. It's not going to harm any counters, or it's not going to hurt if it's used on wood, aluminum, vinyl, stainless, any plastics, tile. It can be used on every single item out there, every countertop, every floor, including wood. I know when you're working with wood, you never want to put a high moisture on there, but you can damp it very, very slight and just kind of wipe it across, and it will also work on wood as well. So going into Cover Shield, Cover Shield is a second product that we have, and that's pretty much our insurance to our products working and lasting a long time. We've done testing, 30-day testing, 60-day, and 90-day testing that was successfully done against 229E human coronavirus. It works like Selectricide. It does do a physical kill, but it lasts without abrasion. So in other words, if you were to spray it on your walls, it's going to last. If you spray it on the cabinetry, we don't want it on food items like countertops. We want it on the cabinetry. We want it on the walls, ceilings, floors, your desk, everywhere around your desk. We want to spray it on those items, and it's going to keep working. There's a video that we're going to show in a minute. It's only like a 2.5-minute video that will explain the Cover Shield a little bit, and then I'll come back to talking about it. So
I don't have Hey, Joel, I don't have the ability to play the video, but I will link it so folks can watch it. Maybe we can describe what it is. I don't have the ability to do it on this.
Great. So if you go onto the TKO website, there's actually 2 videos, one for the Cover Shield and the other one for the Selectricide. So it's one of them is like 6 minutes, one is 2 minutes. So what it does is it's going to show how the Cover Shield, when it's sprayed, it has a killing power by having it does electrocution. It inhibits bacterial growth of any pathogen. So in other words, it creates a biostatic. So when you spray your walls, it's going to pull it like a magnet. It's a positive charge, and the pathogens that are out there is a negative charge. So it's going to pull it, and it's actually going to kill it. 100% it's killed. It cannot create a biofilm because it's 100% gone. Where other products out there, when you wipe them, it sometimes creates a biofilm because it's actually not killing. So with the cover shield being on the desktops, being on the walls, what have you, it's always going to be working 24 hours a day, 7 days a week. Doesn't matter. It doesn't discriminate. It likes every out there, and it doesn't stop working. It doesn't stop killing. So what we're trying to do is create an indoor air quality. By doing that, by cleaning and disinfecting your counters, by spraying the cover shield to have that continual cleaning, it's always going to have, you're going to have a better established indoor quality system. So we can come out, we can train your custodials, we can do the service for you, whichever works best. But we can also train everybody to use our products. It comes in different packages, so we can create small packages as well as up to 30 gallons, and it lasts a long time. It goes a long ways. It is a bactericide, it's a viricide, so it does kill and an algicide as well. So it does kill, and it continues to kill, both of them. We've actually this is not a new product. We've been working with this for over 10 years. We have documents to prove that. And when you spray the selector side, it doesn't work against the cover shield. It actually works with it. So if we sprayed it on door handles that are highly used every day, perhaps like in a hospital or a school, and it's being touched hundreds, if not thousands of times, all we have to do is get a little spray bottle and just touch it up. We just want to touch up those areas. So the cover shield continues to work. We want it to work continuously. If we just do those touch-up, work with your custodials to do that, you have continual coverage. So somebody asked me yesterday, what is it, how are more pathogens transferred? Is it aerial, transferred by air, or is it by surface? It's actually 80% of all viruses are transported by air. So we want to work simultaneously with the HVAC company that's there. We want to clean the HVACs and work with them, because 70 to 80% of the air that you're breathing in most buildings are going to be air conditioned. So all these pathogens that are up in the air, they're traveling. There's only 20% that are surface. Even though we want to continually clean the surfaces, we really want to clean the airs. And that's why it's so important to spray this antimicrobial on the wall ceilings, because it's always working. It's always pulling the negative charges or the germs. So what is the difference between our disinfectants and others? Ours does not allow anything to mutate. It's 100% kill. So it's going to kill everything out there. And that's the whole difference, is ours does not allow it to just mutate it. It's 100% kill. Now, looking at the hand protectant, you're looking at the Q8. It is an FDA, EPA approved product. It has passed the late last year, it actually passed the 229E human coronavirus test on killing the coronavirus. It did it in, I believe it was 60 seconds or 58 seconds, I believe. The product lasts you're looking at the screen, it says 4 hours. We've actually had it tested 4 to 6 hours, so it does last sometimes a little bit longer. So if you're working in an office environment and not working with like masonry, where it's more abrasive, it'll last a little bit longer. And all you need is one drop. Each bottle, it's a small bottle, it's calibrated, it's pre-calibrated, so you just need 1 little ounce of it, 1 little pump of it, and it's going to last you 4 to 6 hours. So each bottle lasts approximately 200 and I believe it's 225, 230 uses. It is a xylene-based product. It has 0 alcohol. It has 0 chemicals in it. It does help heal the skin. It has oils in there, natural oils. And we're actually going to be changing the name of it in the next probably 2 months. We've got approvals to change the name, and we're going to call it Skin Guard. And the reason we're going to call it Skin Guard, it doesn't just work now for the hands, it works for the entire body. So because acne is a bacteria, so we can actually put it on our face and what have you, and it's going to get rid of the bacteria. So if you have a cut, you can put it on the cut and you can clean it with that and put it on there, and it's going to actually help heal the skin faster from the inside going outward. We can give you a lot of testimonials on things like that. The chlorine dioxide, you're looking at.
Joel, jump in real quick. Joel, could you mention only comes in a bottle, but now it's going to be expanding to dispensers and floor dispensers and things of that nature, so they can see the broader picture?
Yes, I'm sorry about that. Yes, we have two dispensers coming out in approximately 2 months. We're working on the third one. One is going to be a foot pedal, so you don't have to touch anything. Doesn't have batteries, so it doesn't go bad. It will dispense. It's 33 ounces. It's over 6,500 uses. It'll go that long. We'll have another one, 33 ounces as well. You can put it on the desktop. And then we're going to have another one that's going to be wall mounted. So we're working with a company. Should have it ready to. We should have it ready for ordering in approximately 6 to 8 weeks at the very latest. So.
Hey, Joel.
Yes, sir.
When they put it on their hand, how they can still wash their hand and still use, which they're required to do, going in and out of the room every day, the alcohol-based ones, and it won't penetrate their hand and it won't take away from.
Absolutely. Yes, you can wash your hands as many times as you like. It's not going to wash off. It'll still stay on there. It'll still keep working a minimum of 4 to 6 hours. It doesn't have any chemicals in there, so it's not going to harm your skin. It has 0 alcohol, like I said earlier, and 0 alcohol, so it keeps working. So yes, and you can put gloves on it, and it's actually not going to dry your hands out like your typical alcohol-based products, where it dries your hands out. Ours is not. It's not going to dry your hands out at all, 0, and it'll keep working even with or without gloves. And the reason we actually had changed the name is at one time we were thinking about calling it InstaGlove, because that's what it did. It created a glove for you, so it protected you against everything, and it worked very, very well. So,
hey, Joel,
yeah.
This is Jason with CAF. We're getting towards the end here. I want to ask you a couple of questions, if it's okay, and kind of explain why I asked you guys to present. And I thought that the opportunity and what these folks are talking about, the products that these folks are talking about, are new in that the chlorine dioxide has been a cleaner, right, or has been in use for a number of years, but it's the ability to kind of make that a smaller source, and we don't need all of this stuff to use it. And that's why I wanted to have you on there. So can you talk for a second about what the actual chlorine dioxide is, and how your product was able to get it into a little container, if
Okay.
you will.
Sure. And in the past, chlorine dioxide, it's been used for many, many years. A lot of times, if you had a home or a business, it had to be draped completely, just tents it over, and you would use the chlorine dioxide, and it would kill every single organism known to man, every single one. But it also did another thing. It destroyed electronics and sometimes even plumbing. So it wasn't too effective. In many buildings, I mean, it worked very well, but it did a lot of damage as well. The chemists that I've worked with and have been working with for a number of years to perfect the products, he made it in a very small pouch, where if you just have one room, like a classroom or any room, surgery room, we can just put one gas pack in there. We have 3 different sizes, 25, 50, and 100 grams. 100 grams will do approximately 200 square feet. So we can put one gas pack in there, close off all the doors, the air returns, and just gas that one area, and it will work really well by killing. It'll take about 4 to 6 hours. If we have 4 to 6 hours to play with, we can set this gas pack off, and it'll just work very, very slow and kill everything in there. But we also have it, and that's the gas form, but we also have it in a liquid form. If we don't have 4 to 6 hours to work with, what we can do in there is we can go in there and spray it, and then we'll wipe everything down, wipe every single thing down, and spray the cover shield afterwards, and it'll protect that area. And typically we can do a 200 square foot room. All we need is approximately an hour and maybe 20 minutes, hour and 30 minutes to do that. And it doesn't matter how many things are in there, we can still get it done pretty quickly. So the difference has been that our gas packs, we're able to do small areas, and if it's a large area, it's 1,000 or even 100,000 square feet, all we have to do is add the gas packs. We're also coming up with a 200 grammer that'll do even more, and it's a faster gas release where we're not going to need 4 to 6 hours. All we're going to need is approximately an hour and a half to 2 hours, and it's going to do the same thing. So we're trying to get that perfected. Actually, it's been perfected. We're trying to get it approved so we can actually use it. So we didn't invent chlorine dioxide. We just invented the process of doing it. The process that we're training people to do is we can show the average custodial to use our products. If we just train them, it'll take probably one good day to work with your custodials, and we'll give them a written test as well to show them how to mix the products, how it can be used easily in every environment in your building or home, and it doesn't cost a lot. It goes a long ways, and it doesn't cost a lot. Did I answer your question?
Yeah, no, that was fantastic, and thank you for that. And I sadly I've got to move us along and get to the remainder of the questions if I can. And if you guys can hang out with us, I can't see an end to these questions, but when there could be some here for you guys. So if you could just bear with me for a second while I finish the remainder of the questions for the folks. And I'm for the listeners, I'm going to put the contact information for Travis and Ken up on the board. And if you're interested in connecting with them or to have a team come out and look at your building, their contact information there is at the bottom. So let's get to the questions now. So we left off with the question about the N95s for folks. Regarding, we'll hop to the next question. Regarding ALF visitation, it will be behind closed doors in their own room, so monitoring will not be possible, and that's true. And I don't think that's unique to assisted living. That will occur in skilled nursing as well. I can imagine if you have the curtain drawn in a room and the visitors are on the other side of the curtain, you're not going to be able to see that. And that's kind of why one of my recommendations would be to have a space in which that you can do visiting and only visiting in that space. For next question, for compassionate care, not end of life, what is the expectation for duration of visit and frequency? And I don't think there's a limitation to visit or frequency, or for duration of the visit or frequency. And I would say whatever you can operationalize that doesn't present a risk to the others in the building is really how you need to boil it down. So if the person coming for the compassionate care visit is unvaccinated and untested, and you're in a purple county, all those things are red flags, for exposure risk. And so we would want to limit the time in which we do that, where it's being done within the facility, frequency in which it's done. All of those things will factor into making that decision. and it would be different for each facility. As for how a surveyor would view it, I think the AFL is open for interpretation, so there's no set requirement to have it this many times a week or at this cadence or for this long. Next question, in relation to optimizing the supply of N95 masks, can visitors keep the N95 mask for other visits unless the integrity of the mask is compromised? And like I said, you know, we're going to hand folks PPE, and we're going to say, look, if you're going to visit in the yellow zone, you have to wear all of these measures. That N95 mask, you know, that is their mask. Here you go. I would not reuse the N95 mask because I don't know what's going to happen with that N95 mask when they take it home. They're going to shove it in their glove box or whatever. I don't know. So if you can, if it's within your capacity, I would highly recommend just, you know, giving them a mask when they come in. How do we determine what type of N95 mask to give to the visitors? Would it be dependent on what we have in stock? Yes, absolutely. And I've gone on to think about this, that we can probably, and I'm going to approach CDPH. I know they still have some of those BYD masks in stock. This seems like a perfect opportunity to send a supply to each facility in the state so that they could use it to help folks visit their family members. Might Mark or someone provide a template for the visitor attestation? And Patty can co-sign this one, but we've talked to legal counsel, and they've felt like this would be something that would be site specific and not conducive to a set template. But I'll bring that back to CAF leadership and ask them if they can revisit that again. And do we need visitor testing every week they visit? And so the cadence in which you're going to test those visitors, if they're a part of the requirement to test, is you're going to test them at the same cadence as your staff. So if you're testing your staff twice a week, you're going to test that person twice a week. If you're testing at once a week, you're going to test that person once a week. Or if they're visiting less than that, obviously test them as they come in. Per AFL 2022.6, red zone can have outdoor visits. Yes, that means they can leave their room to journey through the red zone to go to the outdoor area. The same idea for yellow zone residents in isolation. AFL specifies yellow, exposed, or observation status, but doesn't state anything about COVID recovering. Are they not allowed indoor? Yes, so if somebody's COVID recovered and they're in the green zone, they're allowed indoor in-room visitation, absolutely. In purple counties, there's a restriction on the indoor in-room, but yeah, they are allowed. Let's see here. Sorry guys, there's a lot of questions. I'll keep going for another 5 minutes. I've got another call to get on. I apologize. The screening form for indoor visits shouldn't document date and type of test or dates the vaccine was given, or should document date. You know, what I would suggest, and please, this is my suggestion only, is I would try to put the onus on the signing party that they're attesting to the accuracy. I would say, look, in order to visit, you need to meet these 8 bullet points. Have you met them all? Yes. Sign and attest and date those, and then you have your proof. I would limit what saying when did you get your vaccine or when did you get your test, and what I would develop a checklist and say, if you answer yes to any of these, your visit's going to be restricted. If you answer no, you're good to go, sign, and you're in. That's the way I would do it, but it's up to you how you would get through that. Is ACA or CAF going to come up with a waiver template? That's the second time this has been asked, so maybe I will bring that back to the CAF leadership to see you. The brief touch for fully vaccinated residents or visitors is mentioned in outdoor and in-person in-room. I don't see it for large communal. Was that an oversight? Yeah, so the touch is for fully vaccinated is only has to do with the vaccination status. It should be allowed in any of them as long as the fully vaccinated resident, fully vaccinated visitor. For LA County, can unvaccinated visitors visit vaccinated residents if we use our communal dining space? And I'd have to go back and let me go back and look at that information real quick. Well, I'll have to find the answers for that, Marilyn. And I see you've left, so I'll I'll address it on the next webinar. All right, we've gotten to 2:05, guys. There's probably like 50 questions still, or 50, quite a few. So I apologize, I've not gotten to them all. I will try to address this, again next week. I know it's a ton of questions. I'm sorry that we haven't had a chance to get to all of them. I will endeavor to get to all these questions by the time we meet again next week. Next week, we're going to go over after action planning or after action reporting and improvement planning, and I'm certain we will address the changes to the CDPH AFL 21-08, which talks about quarantine restrictions after exposure for fully vaccinated healthcare personnel. So I talked forever. I want to thank our guest speakers. I'm sorry we had a little technical issues getting through the process. Thank you to our speakers, Ken and Joel. Yeah, thank you guys very much. And really, guys, I did a disservice to the product. This product is different than the stuff that I've been reviewing, and that's why I highlighted it as the best practice. Certainly reach out to Ken if you have any questions about that. So with that, I want to say thank you, guys. Yeah, thanks. Hopefully everybody has a great weekend. We're 1 year in. We're almost there. We got a little bit further to go, guys, but we'll talk to you again next week. Have a great weekend.